Salutations, peace and blessings upon our Prophet Sallallahu Alaihi Wasallam and his entire household. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Good morning, everyone. I am Dr. Nyer Firdoose, consultant oral and maxillofacial surgeon at Riyadh Special Medical Center, Cluster 2. The topic of my presentation today is hemostasis in oral surgery, and my presentation profile will be as such. I'll be talking about the introduction. I'll be talking about the normal coagulation process, the adverse effects of surgical bleeding, the clinical implications of surgical bleeding, surgical hemostasis techniques, key considerations in the selection of hemostatic products, and finally, I will conclude the presentation. Hemostasis is an act of restricting or stopping blood flow from damaged vessel or organ. This is derived from Greek words hem meaning blood and stasis meaning to halt. Bleeding is one of the complications that can occur during dental surgery or any oral surgical procedures. It can present as an oozing at the extraction site or severe intraoral hematomas that compromise the airway, causing anemia, hypovolemia, and can also be life-threatening. This occurs in three stages, like primary hemostasis, secondary hemostasis, and finally fibrinolysis. Before we continue with hemostasis, we need to understand what exactly hemorrhage is. Hemorrhage following or during surgery can occur due to either local or systemic causes. In a healthy individual, the postoperative bleeding is mainly due to local causes. When we talk about the hemorrhage type, it can either be a capillary type, which is slow and even flow, and the color is bright red, or it can be venous type, wherein it is steady, slow flow, and the color of the blood is steady and dark red. And the third type is the arterial hemorrhage or arterial type, which has a spurting blood flow and pulsating, and also the color of the blood is bright red. It is important for all of us to know these normal values of bleeding time, clotting time, and prothrombin time. The bleeding time ranges from 2 to 8 minutes in adults and 2 to 12 minutes in children. It is longer in females than in males. The clotting time ranges from 8 to 15 minutes, whereas the prothrombin time ranges from 10 to 14 seconds. The partial thromboplastin time ranges between 25 to 35 seconds. Coming to the causes of hemorrhage, this can be either local or systemic causes. The local causes are either infection or injury or trauma, which would tear or rupture the vessel wall and disturb the clot. Whereas the systemic causes include hemophilia, hypotension, individuals on anticoagulants, vitamin K deficiency, low levels of platelets, and liver disorders. The amount of blood lost as a result of hemorrhage can range from minimal to significant quantities, as you can see in the bottom right figure, wherein there is an extraction of a lower left third molar with minimal blood loss. But in a similar patient of similar case with a different patient, the blood loss is excessive, wherein you can see the blood pooling into the vestibule. Hemostasis is a complicated process. It involves three phases or events, that is vascular event, the platelet phase, or the activation of the coagulation phase. In the vascular phase, when the blood vessel is damaged, the vasoconstriction occurs to reduce bleeding as a physiologic mechanism. This leads to the activation and aggregation of platelets, causing formation of platelet plug at the damaged surface of blood vessel, which causes activation of clotting mechanism, which converts the fibrinogen to fibrin, wherein the platelets bind with fibrin to form a blood clot. There are certain dependent factors for hemostasis, such as the vessel wall integrity. This gets compromised with major trauma or laceration. There has to be an adequate number of platelets. The less number of platelets than normal. The normal platelet count, which has a normal value of 150,000 to 400,000 per microliter. And the proper functioning of platelets is also very important. The adequate levels of clotting factors is very important. Proper functioning of platelets, and because platelets are required in coagulation process, because their aggregation begins with the initial formation of a platelet plug, and the higher the normal Higher than normal number of platelets leads to thrombocytosis, and lower levels lead to thrombocytopenia. Therefore, a proper function, and finally, a proper function of a fibrinolytic pathway is also very important. Coming to the consequences of loss of vessel wall integrity, vasoconstriction, this is an initial phase which limits the flow of the blood to the area. And then there is formation of the platelet plug. And usually after vasoconstriction, the platelets are activated with thrombin, and they get aggregated at the site of injury to form a temporary loose platelet plug. This clumping activity is stimulated by a protein fibrinogen, and the platelets binding to the collagen, they get exposed following rupture of the endothelial lining of the vessel, which is injured. Now these activated platelets release serotonin and phospholipids and lipoproteins and other proteins which are important for the coagulation cascade. In addition to the induced secretion, the activated platelets also change their shape to aid in the formation of the hemostatic plug. Then the fibrin clot formation. This happens to stabilize the initial loose platelet plug, and a fibrin clot or a mesh forms to trap the plug. This plug is made up of only platelets and is called a white thrombus, whereas one which is made up of red blood cells is termed as a red thrombus. And fibrinolysis eventually occurs. A clot must dissolve to allow the normal flow of the blood after the tissue repair occurs, and this occurs through the activation of or the action of plasmin. The coagulation factors are proteins that cause successive reaction in the clotting process in a cascade-like sequence. That is, one factor is required for the activation of the next factor, and the number associated with the factor, however, does not reflect the order in which it is involved in the coagulation cascade. The lack of any coagulation factor can impair the clotting process. And finally, all coagulation factors are produced by the liver except one liver factor. Coagulation is a process that changes compounds circulating in the blood into a soluble gel, which is able to plug leaks in the blood vessels and thus stop the loss of the blood. The coagulation cascade is one of the key components in the cessation of the bleeding or hemostasis, and by generating a fibrin mesh that stabilizes the activated platelets. Two pathways are established, that is, the extrinsic and the intrinsic pathway. Both result in the activation of the factor 10, which leads to the conversion of prothrombin into thrombin. Finally, the thrombin gets converted. The thrombin converts fibrinogen to fibrin and triggers the activation of factor 13 to cross-link the fibrin strands and stabilize the clot. Eventually, a stable clot is formed by activated platelets, fibrin, and factor 13A. During surgery, uncontrolled or diffuse bleeding can lead to multiple clinical and economic adverse patient outcomes. These adverse effects include visual obstruction of the surgical field. The significant visual complication created by uncontrolled bleeding contribute to increase in the operating time and also increases the risk of inadvertent patient and staff member injury. If not managed properly, a surgical bleeding extends the length of the surgical procedure and can increase the patient's need for blood transfusion, and incorrect blood component transfusion resulting in hemolytic transfusion reactions such as the transfusion-related acute lung injury. This remains to be a major source of morbidity and mortality. And massive blood loss during trauma surgery or long surgical procedures can cause a reduction in the patient's core temperature, and temperature loss has a direct effect on clotting. And the platelets begin to lose their ability to aggregate. This is known as hypothermic coagulopathy. And thrombocytopenia is a common hemostatic deficiency that may develop during surgery because of massive blood loss requiring replacement of platelets. And the effect of thrombocytopenia include hemorrhage or thrombotic events. And hypovolemic shock occurs as a result of vascular volume depletion due to hemorrhage during surgery and can reduce cardiac output because the heart is unable to completely fill. The economic effects of bleeding can be substantial, primarily because of the increased need for patient monitoring with specialist consultations, It can need extended length of hospital stay. Further surgical intervention may be required, and longer procedure times and or return to the OR. And post-operative intensive care unit stays can also be prolonged, requiring mechanical ventilation and additional medical interventions. Minimizing blood loss and reducing the need for blood transfusions during surgery are associated with beneficial outcomes for the patient, such as shorter stays in the ICU and the hospital, and lower risks for infection and post-operative complications. All of these benefits translate to a decrease in healthcare costs for both patients and healthcare facilities. However, if blood loss is not stopped and volume replaced, compensatory mechanisms eventually fail when the following events occur. Like it's already been discussed, vasoconstriction, this reduces oxygenation of the peripheral cells, and the oxygen deprived peripheral cells begin to function anaerobically, and the metabolic waste products begin to build up in the cells. The cells begin to die and release inflammatory mediators. This cell death and inflammatory mediators cause capillary permeability and vasodilation, and the blood pressure falls as a result of vasodilation, and the patient eventually dies. During any surgical procedure, maintaining the delicate balance between bleeding and clotting means that blood must continue to flow to the tissues at the operative site, while the surgical team prevents excessive loss of blood. Therefore, a review of the clinical implications of surgical bleeding might be helpful in understanding the importance of effectively managing this balance. In simple terms, a hemostatic agent. When we talk about the hemostatic agent, how does an hemostatic agent work? This works by quickening the natural blood coagulation response to any injury. That means that hemostatic agents speeds up the healing process, and this is extremely helpful in emergency surgery and other situations with major blood loss. The eventual goal of a hemostatic agent is to encourage lasting clot formation, which directly or indirectly will occurs during the time of injury, and this is achieved via following steps. Either in the step 1, it has to come into contact with blood. When the hemostatic agents are applied to the surface or the wound, a contact is made between them and the blood flow, and then that's how the hemostatic agent works. Or the other way is it activates the clotting cascade. For example, upon the application of hemostatic agent, this gets in contact with the surface of the skin or the bleeding area, and the active substance within the hemostatic agent initiates the coagulation cascade. This coagulation cascade occurs when a series of clotting factors in the blood plasma cause soluble fibrinogen to change to insoluble fibrin, and at this point the wound stops bleeding. Coming to the clinical implications, multiple factors contribute to the bleeding during and after surgical intervention that are related to either the surgical procedure itself or the individual patient, and can have a profound effect on expected outcomes. Let's see now what these patient factors are. When we talk about the patient factors, we have to be we have to be informed about the specific anatomical considerations. We have to be informed about the medical history of the patient, such as if the patient is on certain medications, such as anticoagulants, and if the patient is suffering from any coagulopathies, such as platelet dysfunction or deficiency of the platelets or fibrinolytic activity, and in case the patient is having any coagulation factor deficiencies, and also certain medical conditions or comorbid conditions such as cardiac ailments or hypertension, and finally nutritional status such as anemia. The procedural factors contributing to hemorrhage are type of the procedure itself, the patient position, the surgical incisions, and the amount of bone which is exposed during the surgery, and in case there are large surfaces of exposed capillaries, and unseen sources of bleeding or the tissues that cannot be sutured. There are several methods available to manage bleeding in the OR, including mechanical hemostatic techniques, thermal or energy-based methods, and chemical methods, which include the use of topical hemostatic products. Talking about the individual mechanical methods, direct digital pressure. The use of direct pressure or compression with one or more fingers at the bleeding site is typically a surgeon's first choice to attempt to control the bleeding, as this may be the most simplest and the fastest method. The use of fabric pads or gauzes or sponge in applying the direct pressure and packing a body cavity where the bleeding occurs. And it is pertinent that the number of sponges used should be counted before placing and while removal, because this is just a temporary measure, and any sponges or gauzes or fabric pads which are left in situ at the bleeding site may lead to foreign body reaction later on. And moreover, the compression or other mechanical methods may not always be appropriate in such cases of extreme bleeding, and there is always sutures, staples, or ligating clips to achieve hemostasis. For the last several decades, thermal modes to achieve hemostasis, example, heat generated from electrosurgery, ultrasonic devices, lasers have become feasible options to control surgical bleeding. When any energy-based tool is used for hemostasis, all members of the perioperative team should understand the underlying principles of the modality and use safety precautions during its use. The electrosurgery was developed in the 1930s. This is the use of high-frequency alternating current for cutting, coagulation, and vaporizing tissues in both open and laparoscopic procedures. The electrosurgical energy is delivered in two modes, either monopolar or bipolar, and a complete electrical circuit is necessary for current to flow when using either of these modes. However, the circuits are different, and electrosurgical units are considered high-risk equipment. Therefore, potential risks of electrosurgery may include patient injuries, user injuries, fires, and electromagnetic interferences with other medical equipment and internal electronic devices. The argon enhanced coagulation technology uses a stream of inert non-combustible argon gas to conduct the electrosurgical current. You can see the top left figure. And the ultrasonic devices, this converts the electrical energy into mechanical energy that oscillates longitudinally at a point of contact at a vibration speed of 55,000 times per second, and it simultaneously cuts and coagulates and can seal a vessel up to 5 mm in diameter, and offers an alternative to electrosurgery for some surgical procedures. And the instrument used, you can see in the center of the slide. And finally, the lasers. As you all know, lasers they are the common heat-generated devices used by surgeons to provide hemostasis, and which stands for light amplification by stimulated emission of radiation. In the chemical methods, we have the pharmacological and the topical hemostasis, which again are divided into passive and active agents. Let us see individually now. In the pharmacological agents, the primary pharmacological agent is epinephrine. This causes vasoconstriction and increases the heart rate. Can be applied topically or injected with local anesthesia. Cotton or gauze impregnated with solutions of ratio from 1:100 to 1:10,000 epinephrine. And the second one is vitamin K, which is administered preoperatively to reverse the effects of warfarin and to avoid need of transfusion of fresh frozen plasma. And it's also used in the reversal of raised INR, which takes approximately around 24 hours. And we have protamine, which is the only agent with the ability to reverse the heparin anticoagulation. And this can cause anaphylaxis or acute pulmonary vasoconstriction, and sometimes even it is known to cause right ventricular failure. The other pharmacological agents are desmopressin. This stimulates the release of 1-milliband factor and enhances primary hemostasis. And there are lysine analogs such as aminocaproic acid or tranexamic acid 4.8%. These are antifibrinolytic and competitively inhibit the activation of plasminogen to fibrin, plasminogen to plasmin, thereby preventing the degradation of fibrin. This can be used as a mouthwash also. And both of these lysine analogs can be used topically or systemically. I'm sorry. And coming to the topical agents, the passive type, the passive agents, these rely on fibrin production and hence can be used only in a patient with intact coagulation cascade. They provide a physical lattice-like matrix that adheres to bleeding site, which activates the extensive clotting pathway, leading to platelet aggregation and clot formation. The passive agents are mechanical products, examples of which are collagen-based products, cellulose, gelatin, and polysaccharide spheres. They can absorb several times their weight in fluid. However, this expansion you have to be very careful because this can cause complications like compression of the surrounding tissues leading to necrosis. The collagen-based products are activated with bleeding. They provide a stable matrix for clot formation. They enhance the platelet aggregation. The degranulation and the release of the clotting factors also is aided. And finally, the collagen-based products are derived either from bovine tendine or bovine dermal collagen. Excuse me. The microfibrillar collagen hemostat or avitine. This is derived from pure bovine dermal collagen, and this is an effective agent when there is capillary or venous or small bleeder. It inactivates the thrombin as a result of the pH factor, and the potential adverse events may be the allergic reaction, adhesion formations, inflammation, potentiation of infection, and abscess formation. And there are some products such as the absorbable collagen sponges, and they are derived from purified lyophilized bovine dermal tendon. They adhere to the surface when wet, but not to the instrument. So this is a very good quality of absorbable collagen sponges. And the collagen sponges get absorbed within 8 to 10 weeks, and the bleeding is stopped within 2 to 5 minutes. The other collagen-based products as oxidized regenerative cellulose, which is also known as commercial name is Surgicel, and this reacts with blood. It increases in size when in contact and forms a gelatinous mass after around 24 to 48 hours and promotes clot formation. The potential adverse events with the Surgicel is encapsulation of the fluid and foreign body reaction. There might be stenosis of the vascular structure. There might be burning or stinging sensation, and it is also known to cause headaches. The other collagen-based products are gelatins or gel foam. This is derived from purified bovine gelatin solutions and can be used in either dry or wet form. This conforms easily to wound and therefore can be used for irregular wounds. And the other types is polysaccharide hemospheres. This is derived from vegetable starch, contains no human or animal component. It is available in powder form with a bellow applicator. And finally, we have the chitosan derivatives. The chitosan derivatives are positively charged polysaccharides derived from shrimp cell chitin. And this is the newer generation of hemostatic medical products that have been shown to achieve early hemostasis as well as improved post-operative healing. The topical agents, the active type, they have biological activity which directly participates at the end of the coagulation cascade. They stimulate the fibrinogen at the bleeding site to produce the clot. They activate the active topical agents. They provide hemostasis within 10 minutes, and they may be more effective in controlling bleeding compared to the passive agents. The active agents, there is a thrombin products, which is either bovine thrombin or pooled human plasmin thrombin or recombinant thrombin. The bovine thrombin, this is applied using a pump or spray, which comes in a kit or is in a saturated absorbable gelatin sponge. And the adverse effects of the bovine thrombin is antibody formation to bovine thrombin, can lead to coagulopathy, allergic reactions, or even death. The second type of thrombin which is the pooled human plasma thrombin. This is delivered via saturated absorbable gelatin sponge, and it has a potential risk of viral or prion disease transmission. Finally, the recombinant thrombin type. This has a reduced risk of antibody formation, and it eliminates the risk of viral or prion disease transmission. So, in comparison with the bovine thrombin and the pooled thrombin, plasma thrombin, pooled human plasma thrombin, the recombinant thrombin has an upper edge. The flowable hemostatic agents, they combine the passive and the active hemostatic agents into a single application product. They work by blocking blood flow and actively converting fibrinogen to fibrin, and they come in two types of products, such as absorbable bovine gelatin plus the pooled human thrombin, or the second type is absorbable porcine gelatin plus either of the three thrombin types. Now, the flowable agents do not contain fibrinogen, hence direct contact with blood is necessary for it to begin action. And these are indicated for all types of surgeries except ophthalmic surgeries. And the adverse events include arrhythmias, arterial thrombosis, atelectasis, arterial fibrillation, hemorrhage, infection, pleural effusion, and right heart failure. The sealants, they work by forming a barrier that is impervious to the flow of the most liquids. There are four types of materials approved for the use as sealants to manage the surgical hemostasis. The sealants are either fibrin sealants or polyethylene glycol polymers, albumin with glutaraldehyde, and the new cyanoacrylate sealants. Let's see the individual sealants such as the fibrin sealants. This consists of a concentrated fibrinogen and thrombin, which upon mixing with blood creates a fibrin clot. And this increases the rate of clot formation by providing a high concentration of both fibrinogen and thrombin at bleeding site. And the fibrin sealants are three types, that is pooled human plasma and individual human plasma with bovine collagen and bovine thrombin, or pooled human plasma and equine collagen. And the fibrin sealants, they can be used in patients with coagulopathies and also in patients receiving heparin. The clinical concerns with the use of fibrin sealants is the difficulty of reconstitution or time taken for surgeon to learn the application of the fibrin sealants. And like all other agents, the adverse events are possibility of viral or prion disease transmission, the antibody formation with bovine thrombin, and swelling associated with collagen use. The polyethylene glycol polymers, there are three types: co-seal, Duracell, or Proseal. The co-seal is a combination of two polyethylene glycol polymers to form a synthetic hydrogel matrix. The polymers cross-link to each other, and when come in contact with the tissues, they form a barrier. The Duracell is a combination of single polyethylene glycol and trilysine amine and the blue dye. And on combination, they form a hydrogel, that is, they give a watertight closure or watertight seal. Finally, the Proseal type is a polyethylene glycol polymer combined with human serum albumin. The only product which is approved by the FDA for lung sealing is the Proseal, and the safety concerns with the use of Proseal is swelling, allergic reaction to blue dye, infection, and delayed wound healing. Albumin glutaraldehyde, this contains 10% glutaraldehyde solution and 45% bovine serum albumin. The glutaraldehyde cross-links the residual proteins in albumin to cell proteins at wound site and forms a tough scaffold to which clot can adhere. Commonly used for sealing holes around sutures or staple lines in peripheral vascular procedures. And the adverse events with the use of albumin glutaraldehyde is tissue injury, muscle necrosis, formation of emboli, delayed pseudoaneurysms, and sensitivity to glutaraldehyde. The cyanoacrylates is a product which consists of two monomers of cyanoacrylate, two octyl cyanoacrylate, and butyl lactyl cyanoacrylate, and this is formulated to biodegrade slowly and safely over 36 months, so that only small amounts of the degraded byproducts, such as byproducts, for example, the formaldehyde, are produced at any given time. And the cyanoacrylates are intended to be used as a sealant and should not be used as a substitute for sutures, staples, or ligation clips, or any other methods of mechanical closure. It should only be applied after vascular control is obtained. An additional note on alternative hemostatic agents undergoing constant research is the hemocoagulase, which is derived from Rothrops cabius venom, or the snake venom, and the Ankaford blood stopper. This is a combination of natural herbs, mainly found in Colombia and Turkey. And recently, green tea extract is also known to achieve hemostasis. Calcium alginate, the use of hyaluronic acid presently is a hot topic in terms of research for hemostasis and wound healing and regenerative as a regenerative material. The use of aluminum ferrous oxide or other metallic astringents like calamine and alum is also known to achieve hemostasis. The key considerations in selection of a hemostatic agent are it should rapidly and effectively control bleeding. It should effectively contact the bleeding surface. It can be handled easily. It can be prepared easily. It should be available in multiple delivery options, and it should be compatible with the patient's physiology. And it should be safely used, and most importantly, it should be cost effective. After the selection of the ideal agents, let's see its characteristics. It should have the capability to stop large vessel, arterial, and venous bleeding within minutes of its application. When applied to an actively bleeding wound through or pool of blood. No requirement for mixing or pre-application preparation. The simplicity of application, the lightweight and durability, and it should have a long shelf life in extreme environment. And like it's already said in the previous slide, it should be safe to use with no risk of injury or tissue toxicity or the transmission of infection. Finally, why should we use hemostatic agents? We should use it because it should minimize blood loss. It improves the visualization of the surgical field. It saves the operating time. It reduces or avoids need for blood transfusion. It prevents leakage of non-bloody fluids, and it decreases post-op drainage and infection. And also, it should decrease hospital length of stay. In conclusion, the success of any procedure depends on the surgeon's ability to effectively and efficiently manage hemostasis, to provide an optimal view of the surgical field, and to prevent the adverse physiological effects associated with blood loss. It helps to preoperatively assess the patient for risk of preoperative bleeding, to be prepared for any untoward events. Thank you so much, and we open for questions now. Thank you.